Healthcare reform in Washington State. I'm just going to make two preparatory comments. The first is, as is normally often the case, or always the case really, this talk really should take place over a year, not 30 minutes. So I'm covering a lot of material in a short amount of time. Some of it's controversial. There's lots of different views on this. And then the second point that I'll make is, unlike some of the other presentations that I've given, where in my view it sort of leads pretty clearly to a conclusion, this one, that my feeling certainly is not that. There's many different ways for how to proceed on this issue. So with that, I'll get started. As people know, the theme of my campaign is bold structural change, not just incremental reforms. And I've argued that we face 5 crises: public health, the pandemic, the economic recession, the budget crisis in Olympia, the demands for racial justice and climate change. And in light of these, we need structural solutions, not just incremental reforms. I'm advocating against an austerity approach, in favor of a new taxation to aggressively address climate change and to address the challenge of racial justice by getting at underlying causes. So we've talked about that before, but again, my campaign is about structural change. Okay, so for today's discussion, healthcare, I'll talk about sort of the overall crisis, then we'll talk about at sort of a national level, then the state level, and then talk about some of the policy issues currently confronting Washington State. So we'll go from high level to lower level. So I think my first 2 slides, candidly, are as important as any. At least that's my opinion. So it's important to recognize that there are many different healthcare models operating in the world, and this is certainly not an exhaustive list. And these sort of are arrayed from those on the left, where there is no insurance, to the one on the right, which is full national health care. So I'm just going to cover these briefly, and there is a point to this which will emerge on the next slide. So we have countries where a very low percentage of the people are insured, like Paraguay, India, they're in the 20% range. So for the most part, it's fee for service. If you break your leg, you go negotiate a deal to have someone fix it if you can afford it. So that's fee for service, no insurance. That's a model. Second model, 2-pronged approach. So you have, this exists in Singapore, and I'm simplifying vastly, okay? So, and I realize that. But in Singapore, the typical citizen does contract on their own for most of their healthcare needs, but they have insurance for catastrophic events. So that's 2-tiered, okay? Japan has an employer-based system, so you get your healthcare through your employer. It's a little more complicated than that, but that's the fundamental model. Denmark, they have mandates, so you don't get your healthcare through your employer. Instead, there's a government mandate that says that you as a citizen have to purchase insurance, and insurers have to insure you. That should sound familiar to you. It should sound like Obamacare, which it is, but that's the dominant model in Denmark. I'm going to move to single payer because people know the term. Canada, single payer, you pay taxes at the provincial level. You now have insurance, and the payments are all made by the provincial government. There's a variant of that in Germany, a multi-payer system where there's a bunch of different funds managed in effect by the government, and so they call that multi-payer. And then there's national insurance, and a lot of people will say, well, isn't single payer national? The difference between Canada and England, or the main structural difference, is that in England, the country, it owns the healthcare facilities, okay, and the doctors work for it, whereas in Canada, or single payer systems, the facilities are not owned by the government. So national healthcare is fully nationalized. Single payer, it's just the payment part of it that's nationalized. So we have 7 different models, and yes, there are more, but it does make the point there are different models that work, all sorts of trade-offs implicit to different models. I'll just bring up one. In England, you'll see billboards up that say things like, watch out for, fast food, but you won't see that in the States. Why is that? Because in England, a person that is a member of the National Institute of Health, a citizen, they're going to be there for life. So the system has an incentive to try to work with you on your behaviors. But in an employer-based system, especially one where people switch jobs, those incentives don't exist. Cigna's not going to put up an billboard telling you to not eat fast food. So anyway, 7 models, all sorts of trade-offs, and that leads to the next slide. What about the United States? So most people would say we have an employer-based system, and in fact we do, but what's less appreciated is that we have 5 systems, and that's a huge issue for cost. Okay, so in addition to the employer-based system, we also have mandates through the Affordable Care Act, like Germany. We also have 9% of our population that's not insured. So we have an uninsured part. We also have single payer for Medicare and Medicaid. So when you become elderly and contract for medical insurance with the government, that's a single payer system. And the VA system is government owned. They own their own facilities. So a huge part of what drives cost in the US is that we have 5 different systems. There were only 7 on the previous slide, and we have 5 of them operating in our country. That's extremely uncommon. Okay. So what are the results of this? Well, insurance level coverages by country. A lot of countries in the OECD, those are the Organization for Economic and Cooperation and Development countries, advanced countries, most have 100% coverage, or 99.9. We're very low. I don't know if you can see the number there. Yeah, 91%. So we stand out amongst developing countries as a country that doesn't insure that high of a percentage of our population. That leads to problems. A lot of these people purchase their health care at emergency rooms, which leads to higher costs. So that's one area where our system's not ideal. How about cost? We're off the charts. So this is the percentage of GDP spent on healthcare. I think we all pretty much know this. Close to 18% here. The average for other developed countries is half that. And we have a higher GDP per capita than most countries. So if you look at our healthcare expenditure per capita, it's even more than double the OECD average. And we're about 50% higher than the number 2 country. So we spend at an unheard of level on healthcare in the world. We stand out. And they've risen dramatically over the past several decades. From 1965% of GDP on healthcare, now it's about 18. So this is a major, major issue. Okay, I know we all know this, but it's sort of good to review the data. All right, and then the next problem is our outcomes are not good. And there's a million ways to measure outcomes. This is just one very simple metric. This arrays countries by how much they spend per capita and their life expectancy at birth. And so, as you'd predict, there's a general upward trend declining over time, that as you spend more money, your life expectancy goes up. And that's, confounded with the fact that it's more affluent countries that spend more, and there's more to it than this. But it's basically a pretty simple relationship. The problem is we are an outlier again. We spend way more than anybody else, and yet we're way below the curve. So this is about 78 something years, and this is about 84. So our longevity is not what one would hope given our expenditure level. And this sort of trend holds true across a lot of metrics. So we have low coverage levels, extremely high costs, and outcomes that aren't particularly good in a lot of ways. Some outcomes our technology is amazing, but for the rank and file, not that good. This is a similar chart. It shows the trend over time. Other countries, as they spent more over time, achieved life expectancy on this pattern increases, and we increased at a lower level. So on a lower trajectory, even though we're spending more. Okay, why is our US high cost? Okay, and there are probably 500 factors. I've listed just some of them, and so I'm not going to get into which ones are more important. I just want to make the point that it's complex why it's so high cost. Societal factors. We have an aging demographic in the US, high obesity levels, gun violence, high incarcerated population. So now you're spending money on healthcare, but people aren't involved in the economy. That raises healthcare as a percent of GDP. We have a pharmaceutical benefit. We don't have bulk purchasing of pharmaceuticals. Our patents are very protective of pharmaceutical companies, enabling higher costs. We have a lot of technological sophistication. So new devices that are insured lead to higher costs. We have lots of types of surgery, cosmetic surgery. We have lawsuits and high jury awards. Those get built into insurance premiums. Perhaps we're have too high of licensing requirements in the profession so that it's only highly compensated, highly trained individuals that can enter. Maybe it'd be better to relax those, have more nurse practitioners that could handle more procedures at lower cost, etc. The complexity of operating 5 models needs to be emphasized. Huge administrative costs. When I lose my job, now I move on to COBRA. Now I have new insurance costs. Then I move to another company. Is my old insurance policy portable or not? When I get older, now I shift my administrative work to the government, etc. Massive complexity. There's some programs that are shared. Medicaid, the federal government pays for part of that, the state government pays for part of that. Paperwork. So we have all sorts of people doing administrative work in our healthcare system, way more than virtually any other country. And I've talked before, high uninsured populations leads to added costs. People getting care at the emergency room when that's 10 times higher cost than the care that they should be receiving. And this isn't all of them, of course. We have price gouging, companies charging just incredible, rates for pharmaceuticals and procedures. Some companies have pursued the addiction of their population in the opioid field, for example. That adds costs. There's also huge incentive problems. So let's say I'm going to go have a procedure done. My attitude will be I don't care that much about the cost because insurance will pay for it. The company buyer that buys my health care plan will say, this is between the consumer and our healthcare provider, so we really don't get involved. The insurance company is going to bill the company so that they don't worry too much about the cost oftentimes. And the physician oftentimes can take the attitude, I can do these procedures and bill them, so I'm not going to worry about it. And I may need to do extra procedures to protect myself from lawsuits. So we have all sorts of incentive problems. And implicit to healthcare, of course, is asymmetric information where the physician knows way more than the patient. So the patient's not really in a good position to negotiate anyway. So the incentive problem is huge in American healthcare. And then this leads to lots of questions. Should healthcare be a for-profit industry? Is healthcare a fundamental right? We have huge equity issues. Healthcare varies by race, ethnicity, class, urban, rural. Zip codes and life expectancy are highly related, which is unfortunate. We're moving more to the telemedicine, and that leads to issues of equity with respect to internet access. There's efforts to repeal the ACA, so all sorts of major ethical issues associated with healthcare. And the system's resistant to change. If you want to change the U.S. healthcare system, you're going to take on everybody and their brother and their lawyers because they have a vested stake in maintaining their position in an industry that's very profitable. So we have a messy, 5-pronged system with all sorts of complexity, all sorts of incentive problems, all sorts of ways that costs get built up, and this is what underlies our 18% of GDP spent on healthcare with mediocre to poor outcomes. A very, very concerning process and very difficult to change. All right, so that's the overall crisis, a summary. Moving on to Washington State, where do we stack up? So when we move to the Affordable Care Act, there's 2 possibilities for states. They can either accept, move into the ACA full stock and receive additional funding for Medicaid. And so enhance their coverage levels that way. Some states, basically red states for the most part, there's exceptions, California, but they did not accept, many of them, a Medicaid expansion because they didn't want to be part of Obamacare. Consequently, they have higher uninsured levels. So these are states that did not accept Medicaid expansion, and you can see their uninsured levels, 10, 11, 12, up to 18 in Texas. All right, so how about the states that did accept Medicaid expansion, and we're one of them. Here's Washington. Their uninsured levels are, of course, lower. Ours is 7%, and if you look at Massachusetts, Hawaii, very, very low percent of people uninsured. So there's a big range. In Texas, we have 18% of the population uninsured, and in, let's just say, Hawaii, 4%. So huge range, and we're pretty good. Washington, about average for states that took on Medicaid expansion, accepted it, but if we include the other states, above average. A couple more facts about Washington State. You can purchase your Obamacare through a state exchange, and Washington's one of the, whatever the number is here, 11, 12, that created their own website portal for doing that. So sort of advanced in that area. That's called the Washington Health Plan Finder. We're also last year instituted a state level public option to provide another option for individuals trying to purchase health care. So rather than having to purchase it through the companies listed on the healthcare finder, the government is sponsoring an option, Cascade Care. Other states are considering this, so we're sort of a leader in this front. On mental health, we've sort of been a laggard here. Previously, we had a centralized model with two huge facilities, Eastern State near Spokane and Western State in Pierce County, and we're moving to a decentralized model now where these are going to be downsized and these are going to be expanded, which is good during the pandemic as local mental health issues sort of proliferate. So we're in the midst of a transition there. And how do we rate overall? Well, it's difficult to say. So this is some of the top states in terms of performance. I've just cited 3 surveys: U.S. News and World Report 2019, a Commonwealth study from 2018, Money Rates 2020. The reason I included 3 is it makes the point that there are pretty big differences between surveys. So if we look at Washington, U.S. News and World Report ranks our health system based on their criteria as 4th best in the nation, the Commonwealth 7th, but Money Rates 22. So we need to be a little careful about, overly interpreting from one study. But in reviewing the various studies, it seems pretty clear that, generally Washington's healthcare system is viewed as a, better than average, and in some studies, quite good healthcare system. All right, policy updates. So in Washington State, here's some of the issues currently being discussed. I've divided them between pandemic-related and others. So I talked about this. We're moving to a mental health model. The public option that I just discussed, there's discussion about downsizing that during the pandemic-driven Olympia budget crisis. So that might get decreased in terms of size. Can we expand, take measures to increase enrollment in the ACA? And also, we want to make sure we maintain employer health care coverage during the pandemic. There's an article in today's paper that companies are going to start laying off some of the people that they had continued to hire with their PPP, Paycheck Protection Program. That will increase uninsured people, which is concerning. Ensuring regular health care needs are met during the pandemic. There's been an interesting phenomena that people that don't have COVID-19 are staying away from hospitals for regular care because they're concerned that if they go to the hospital, they'll contract COVID-19. So that's concerning. Obviously, we want to make sure testing, tracing, and quarantines are at high levels. Some people have advocated for a summer job program to assist with that. There's a fund that I support, which is a $100 million fund recommended in a non-binding recommendation from Seattle City Council to the state government to allocate $100 million to a fund to protect undocumented immigrants with health care and economic needs during the pandemic. So these are some pandemic-related health issues being discussed. Other issues being discussed, the move to single payer, I'll talk about that in a minute. There's a study currently happening in the state to look into that. The effect of the recent U.S. Supreme Court decision just of a few days ago, religious employers are not required to provide contraceptive care to women, so that will raise health care access and funding issues. There's been work on insulin. Last year, a bill was passed to limit insulin costs to people covered by insurance to $100 a month. There was a bill to establish a central purchasing authority, which didn't pass, so that probably means that'll be reintroduced this year. There was a bill to ban flavored vaping in the last session, which didn't pass. On vaccine objections, a bill was passed to eliminate the personal and philosophical objection to the measles, mumps, and rubella vaccine, but not other vaccines. So that will likely reemerge in the upcoming session. I favor the elimination of the personal and philosophical objection for all vaccines. Pharmacy tourism, allowing the importation on a large scale of vaccine or pharmaceuticals from Canada to the U.S. didn't pass, and there was a bill, a lot of people consider this healthcare, a comprehensive sex education curriculum requirement for K-12 students. That did pass, but it's being challenged in a lot of Eastern Washington school districts because they believe it includes inappropriate material, even though there is a lot of flexibility on curriculum. So this is just sort of an overview of a lot of the issues being discussed in Washington. And that leads to sort of the big issue, or a big issue. What about single payer at the state level? And just before continuing, I'll say I tend to support this, but I certainly think it's an interesting debate to have. So there's an organization called Whole Washington that's working for this. Thus far, unfortunately, in the U.S., the record hasn't been impressive for single payer. Vermont tried it, had all sorts of problems. It was called Green Mountain Care. These other states have introduced initiatives and task forces, and they're looking into it, but it really hasn't been up and running in a successful manner thus far. And I just want to, there's some issues, and then I'll add one. Well, actually, let me stay here. A huge issue is when you move from one system to another, you create winners and losers. So, you know, unions will look at their labor contracts and say, well, if we move to single payer, we're going to be these workers will be worse off, these will be better off. We're going to oppose it. Another union favors it, etc. So it's very challenging to transition in a way that's effective. Is this the right approach, single payer? That's a big issue. Is now the right time? Maybe it's the right approach, but it should be deferred. Some climate activists say, yeah, we're in favor of single payer, but we want to push that off from an agenda perspective because we want the focus now to be on climate change, and you can't address two things that major concurrently. Should this start at the state level, or should it start at the national level? Obviously, it's not going to start under the Trump administration, but possibly the Biden administration. And the transition is difficult, as I talked about before. Where does this stand as a priority? And I thought I'd cite Paul Krugman, you know, well-known Democrat, Nobel Prize winner. And so he's made a couple of comments. If it were up to me, I'd talk about improving the Obamacare, not ripping it up and starting over. I have nothing against single payer. It's what I'd support if we were starting from scratch, but we're not. Getting there from here would be hard and might not accomplish much more than a modest incremental approach. Even idealists need to set priorities, and Medicare for all shouldn't be at the top of the list. Interesting. Later, he says, does pointing out the possibility of incremental progress mean giving up on a truly universal system? No. By all means, let's make something more ambitious, such as Medicare for all, which is another way of referring to single payer, a long-term goal, but it shouldn't stand in the way of policies that would immediately benefit millions of Americans. So I'm not saying, of course, that he's the, you know, the ultimate authority on this, but he's, you know, highly knowledgeable, and it's an interesting perspectives. And so my last slide, what are, you know, next steps in healthcare? And I've sort of segmented them into the three categories that I've, you know, referenced previously. First, obviously, we need to meet the healthcare demands of the pandemic that has, you know, there's capacity implications for hospitals, PPE, et cetera, testing capacity, contact tracing, Inslee's Safe Start phase reopening, you know, that there's all sorts of discussion happening now about how to handle school in the fall. Healthcare issues, I just talked about that. This $100 million fund for undocumented immigrants, which I support. So all of these are, you know, front and center in the healthcare discussion now. There's also these incremental changes elsewhere, and I don't mean, when I say incremental, I don't mean not important. Certainly they're important. But things like, should an insulin task force be set up? Should we allow significant importation of, it shouldn't say vaccines, I'm sorry, it should say pharmaceuticals, from Canada. So these types of debates are important, and there'll be bills introduced in the upcoming session around these. And then there's this, huge looming issue. Should there be efforts made to move towards a single payer system in the state? My position is I do favor exploring this, considering it, and I do favor the single payer model. For me, the big question is how aggressively to move in that direction. But I certainly like it. I certainly favor it. And also, as I've said in a prior talk, can we accelerate the transition to a community-based model, and in so doing, perhaps shut one of our centralized facilities? One proposal already that's been put out is to close 14 different wards, and perhaps it's possible to accelerate it to the point where you don't shut just 14 wards, you shut the whole facility, and thereby enable significant cost savings to be realized, which would be useful in the upcoming budget process. So sort of three levels of, areas, realms, I'll say, of change, and sort of interesting issues in each. We do have a major crisis at every state in healthcare, and as I said earlier, Washington seems to be generally rated as pretty good. So those are my thoughts on healthcare, the healthcare situation. I appreciate people listening, and we will now have time for questions, and Matthew will sort of lead that.
Thank you for the talk, John. All right. I have just allowed everyone to unmute themselves. If you see that prompt on your screen, kindly do so. I guess I'll start off with a question from Ann Stafford. So she wrote at 11:21, when you say military, do you mean active duty military, or do you mean veteran care for service members who get VA medical care based on service-related condition?
Yes, the latter. So what I was referring to was the Veterans Administration hospital network.
All right, thank you. And I see Elizabeth raising her hand. Go ahead.
Hi, I was in California when then Governor Reagan decided to close the mental hospitals, and he said there would be treatment at a local level in community mental health facilities. The result was a disaster for the mentally ill. People were pushed on the street with no support, and those community facilities, frankly, did not really exist. And it was a travesty. I'm concerned that something like that could happen here. I've worked in the mental health system. I was in community mental health. It leaves a lot to be desired. What are your thoughts?
Yeah, all I'll say is that I appreciate your comment. I was not aware of that phenomena in California. What I will say is the overwhelming, there's been huge criticisms of, and even federal crackdowns on the care provided through the two centralized facilities.
Right.
We've had funding withheld, we've had healthcare violations. So at least in our state, those are, as I understand it from following the situation, generally not deemed to have been, a successful model for care. And the overwhelming majority of the commentary from analysts that I've read about our move to the community mental health facilities is positive, that it's good to get out into the community. That's where the issues reside. There's difference between different parts of the state that need to be recognized through how care is provided through different facilities. So everything that I've read, almost everything has been supportive of this concept, but certainly it's going to depend on how it's implemented. If it's if it's not done effectively, well, then, what happened in California could be repeated. So, those are my comments, but I appreciate the input that says that it could work out otherwise. And I think, Mike, did you want to comment on that?
I'm just wondering about the problem of the criminally insane. Shouldn't we perhaps maybe be using these facilities, Eastern and Western, for some folks who are now incarcerated and not really receiving appropriate mental health care in the various penal institutions where they're located.
Yeah, and all I'll say is that's an interesting idea. I am familiar with this phenomena for people that don't follow it. We even have significant backlogs of people, or at least have had, I don't know the situation right as we speak, but of people that have been incarcerated and they can't get effectively diagnosed in a timely manner, where a diagnosis of significant mental health issues would lead to a transfer to eastern or western states. So there's backlogs in our of people needing mental health treatment in our prison system. So your concept of devoting, one of those hospitals or wards in them to that need, that's interesting. And all I'll say is it's interesting and perhaps a very good idea. I have nothing really to offer to that, but it's an interesting concept. So thank you.
Thank you for those questions. Anyone else?
Anybody else? Okay.
Elizabeth raised her hand.
I have another one.
Go ahead.
Yeah.
Okay. One of the things that happened in California was people were released from those institutions and they were homeless. So it's not just a matter of having the professionals, the mental health professionals, distributed as opposed to concentrated. But when people are in that institution, they're housed. So what is the plan for housing the patients who are critically ill and institutionalized once this is decentralized? Thank you.
Yeah, and I guess the only thing I'll say to that is we do have two facilities. Even if one was closed, we would still have sufficient, or I won't say sufficient, but significant capacity to house people in the other facility. I don't know the answer to the question of whether these people could be housed at the community centers. I don't know, community mental health facilities. I don't know how that's going to be addressed. So it's another good comment.
Thanks.
Mario?